Hello, I am Eileen Wang from National Jewish Health, and I'm joined by Dr. Michael Wexler for this clinical brief on biologic monitoring, switching, and discontinuation. Now, Gina has these recommendations for how to assess and monitor those you start on biologic therapeutics. So starting on the left-hand side, recommendations is for a trial of at least 4 months to assess your response to your biologic. So if you go through the middle pathway, if you have a good asthma response and you're looking at the green box and you still want to reevaluate your patient every 3 to 6 months, again, these are severe and they were previously uncontrolled asthmatics. For oral treatments, particularly oral corticosteroids, consider decreasing or stopping due to the increased risk of adverse effects and also other add-on therapies. In terms of your inhaler treatments, consider decreasing these also after a period of good control after 3 to 6 months, but you usually want to keep them on at least a moderate dose inhaled corticosteroid. Also, it's important to reevaluate the need for the ongoing biologic. And also, in terms of choosing which medication to decrease or stop, things to consider are the benefits, the side effects, the cost, and also shared decision making, so patient preference. Now, if it's unclear that you're having a good response to the biologic chosen, the recommendation is to extend that trial to 6 to 12 months for a better assessment. However, if it's clear that they are not having a good response after at least 4 months of therapy, then you stop that add-on biologic therapy and consider switching to a different targeted therapy. You would also consider things in that orange box to include high-resolution CT to evaluate for other etiologies for why they might not be well controlled. Also, it's important to reassess that phenotype and treatment options. Again, a lot of these biomarkers are not static and highly impacted by therapeutics and the natural history of asthma. And also stop the ineffective add-on therapies, but don't stop the inhaled corticosteroids. Now, looking at real world data, so there was a study of about 3,500 adult asthmatics, real world data in terms of the International Severe Asthma Registry and Chronicle study. So these are prospective observational asthma studies. The Chronicle study was conducted in the US. And if you look here in terms of the patterns of this real world use of biologic therapies, almost 80% continued on their first biologic. So it's important to note the years that this data was collected. So for ISAR, it was between 2015 to 2020, and for Chronicle, it was 2018 to 2020. So in this group, about 10% stopped a biologic entirely. Another 10% switched to biologic. The most common first switch, so about 50%, switched from omalizumab to an anti-IL-5 or 5 receptor, which makes sense in terms of the timeline and what the available biologics were then. And also the most common subsequent switch, so about 44%, switched from one anti-IL-5 or anti-IL-5 receptor to another within the same group. What's most important to note here is that more than 90% of the patients in the Chronicle, so the US observational study, continued on their first biologic. So looking at the data from the Chronicle study, so this was an abstract presented at the QuadAI. This is comparing groups who continued on biologics, stopped biologics, and switched. And again, this is the prospective observational study, included about 1,300 patients. And you can see those who continued on biologics had lower percentages that experienced exacerbations in the previous year, had daytime symptoms, and also nocturnal symptoms. And again, it's important to note that more than 90% of patients treated with biologics continued them in this study. Now, Mike, when do you personally recommend a patient switch to a different biologic, and what are some of your criteria for making this recommendation?
So as you mentioned, Eileen, a lot of patients continue on biologic therapies for a long period of time. So when do I consider stopping or discontinuing a biologic? Well, first of all, I think about safety. Is the patient tolerating it well? If they're not tolerating well, or if they have side effects or injection site reactions, that's a no-brainer. You don't want to cause any harm to these patients. Second of all, I'm pretty greedy. I want to have really good biologic response. I want complete elimination of exacerbations. I'm looking for remission with improvement in outcomes. I want improvement in lung function. I want people off of oral corticosteroids. I want them to be symptom-free. So if they haven't achieved that within 4 to 6 months on a specific therapy, that's a signal to me that maybe we should be either doing more of an extensive workup to figure out what's going on, like do those patients have other comorbidities? Alternatively, I might just switch them to a different biologic therapy. And that can be a challenging decision. Otherwise, I continue my patients on for at least a year. After a year, using shared decision making, I discuss with them what are the risks of stopping the biologics versus the benefits. In patients who've responded, the benefit is clear. You want to continue to remain symptom-free, asthma exacerbation-free, and improvement in lung function. There is a risk that if you stop a specific biologic therapy, that you might lose some of those benefits. So for my patients, I usually wait at least a year and then start having a discussion about whether or not the drug is working and whether they'd like to start a new therapy or whether they'd like to stop the current therapy because they're doing so well. I also tell them it's really important for them to continue their regular daily maintenance therapies. That's really, really important in terms of reducing the airway inflammation that's going on.
What do patients tell you are the most kind of frequent reasons that they want to discontinue a biologic?
Yeah, so patients will generally continue a biologic as long as it doesn't cost them a lot out of pocket. That's, I think, one thing. Second of all, if they are having significant adverse effects. Third of all, if the drug isn't meeting its goals, if it's not reducing exacerbations, if they haven't been able to taper steroids, if patients haven't been able to gain functional activity. Fourth of all, sometimes there's just other logistical issues. So some patients are currently coming into the office for some of their therapies, and they can no longer do that for one reason or another. And so then we might consider switching them to an at-home therapy. So there's a lot of reasons why we switch. Those are some of the most common.